if I can just, if I'm sorry about this, but if
now, do you want to do the first case?
I don't mind actually, if you don't mind.
Dr. Amit, is it okay?
Yes,
Dr.
it's
Aisha Qadir does the first case? Yeah, okay.
Yes, it's
Sorry,
okay.
Dr. Amit. I'm just sitting
No,
in the
it's
lab
okay.
and keeping track. I apologize. Let me do
That's
that.
all right.
Then. Thank you so much. Yeah. All right.
Hello, good evening, and welcome to the Complexity Conclave case-based discussion on complex coronary cases, E-Conclave Series 4. And we have with us three presenters today who will be speaking on three interesting cases. And we have with us as chairperson our Dr. R.K. Agarwal. Just to introduce him, that he's senior consultant cardiologist, director, and head of the department of cardiology at Rupan Memorial Hospital, Patna. He was past director of cardiology at Indira Gandhi Institute of Cardiology, Patna, followed by Magad Hospital, Patna, initial centers of cardiac interventions of Bihar. He is one of the pioneers of cardiac interventions in Bihar and is a very well-known cardiologist across India. We also have with us Dr. Amit Kumar. He's consultant interventional cardiologist and head of the department at Arsh Super Specialty Hospital, Gaya, Bihar. And welcome to the show, Dr. Amit Kumar. We also have Dr. Uday Shankar, who is consultant interventional cardiologist at Apollo Multispecialty Hospital, Kolkata. We have with us our international faculty, Dr. F. Ayesha Qadir, who has presented in many of our forums here. She is associate professor and consultant interventional cardiologist at Ibrahim Cardiac Hospital and Research Institute, Dhaka, Bangladesh. Welcome, Dr. Qadir, to our program. So we will just change a little bit of the schedule because of Dr. Qadir will be leaving soon for a case. So I'll ask Dr. Qadir to present her first case in this meeting. Before that, a few words from Dr. Agarwal. Dr. Agarwal, over to you.
Yeah, it's a great meeting, and we'll be learning a lot of things because of the various speakers. So let's start with first with Dr. Ayesha, and let's see what she's going to present.
Thank you very much, Dr. Agarwal, and thank you, Dr. Beniak, as well as Dr. Amit, for allowing me to jumpstart and present ahead of time. I appreciate that very much. So my case is actually titled The Hidden Ghost and the Magic Wand, and hopefully it'll be of interest to you. The brief summary is this was a 70-year-old gentleman who was hypertensive, diabetic, and dyslipidemic. He presented to us this time with CCS class 3 to 4 angina for a few weeks. But in his previous history, we'll see that later. It's interesting because ECG at presentation revealed a prior inferior MI, and he had an ejection fraction on echo of 50% with inferior wall hypokinesia. But his past history was also quite chaotic. 2 years back, he had a STEMI, which was thrombolized at another center, as is often done in our country. And he was then transferred to a PCI-capable center with post-MI angina 36 hours after thrombolysis. Even at the time, his ejection fraction was preserved, and he was then taken for CAG the same day. This was 2 years back at a previous center. And I'm showing you the films because it's relevant to the case presentation. Sorry. So this was 2 years ago. As you can see, the left system angiography showed diffuse calcification, which might be expected given his age, but no significant lesion that required revascularization at the time. And this is the right-sided injection. Mind you, this is an inferior STEMI, but it doesn't look like an entirely acute occlusion. In fact, it even looks like a CTO because with bridging collaterals filling antegradally. So if on further analysis, we can see that even angiographically, this RCA along with a chunk of calcium about 5 millimeter beyond the occlusion. And this is the picture of another plane. These are still pictures from 2 years ago. And as you can see, there's bridging collaterals as well as some nasty calcium. So at the time, the operator did a pretty good job, I would say. They engaged with an Icari right, 6 French for deep intubation, and then took a low penetration hydrophilic. This was a PT2 wire with 1.25 by 5 millimeter balloon support. And here, this was, of course, not predicted to be a CTO because they went on the faith that this was an MI. And even with that, the calcium could be managed by conventional means because this was done at a center 2 years ago and not all modalities were available at the time. So they had done a bit of granuloplasty followed by a meticulous balloon dilatation, both an NC as well as a scoring balloon. Then this is the NC and scoring balloons being inflated. And then they had inflated it, they had stented a 3 by 12 millimeter drug-eluting stent just to cover that spot part, given that this was also in a STEMI setting and they probably didn't want to do too much manipulation. But final picture is satisfactory with at least STEMI3 flow established. So this was 2 years ago and the patient had been on follow-up, but this time he came again, despite that, with angina of increasing onset over the last 3 to 4 weeks. And this time when we took, these are pictures from this time. So we found that the left system remained unchanged as before, but this is the RCA picture. The stent seems to be patent with some, but of course there's instant restenosis just proximal to it as well as distal to the stent there. And yeah, you can appreciate the calcium even angiographically that there's very distinct calcification. So this is the still picture. As you can see, what we have here is a stent, we have a chunk of calcium and an instant restenosis just proximal to it as well. So this time, of course, we came with all options open. We had intravascular imaging, we had NC scoring balloons, rotablation, IVL guide extension. So the full calcium armamentarium was ready to tackle it as and when we might need it. And so in terms of planning, so we, of course, would use imaging to assess calcification. We know OCT is better in this setting, but as we don't have OCT at our center, we proceeded to use IVUS. But of course, the IVUS catheter has to cross in such calcified lesions. So if the IVUS would not cross, we decided we would go for meticulous balloon preparation. And if it didn't cross even then we would need to think of something like rotablation. But of course, we have to mind that there's stent there and rotablation should of course be the last resort. So as you can see, we proceeded with small balloon inflations and there's very severe dog boning, as you can see in these images. So the IVUS catheter didn't cross until we could tackle this. And therefore we went for balloon dilatation. But as you can see, very evidently, there's very significant dog boning at that place. So further balloon escalation was done. And then after we inflated with a couple of NC and a scoring balloon, we managed to get this. And we wanted to take an IVUS catheter down. So fortunately, the IVUS catheter crossed. And this is the run. There's calcification distal to the stent. And let me just show you as you can see here. And in some segments, almost 360-degree and minimal crack, even after ballooning, as you can see here. And there's under expansion of the stent also. So now which one to pick in this setting? We have IVL, we have rota, and we could either use a blend of rotatripsy. But as I mentioned before, there's an asymmetric stented segment there as well. So rotablation should ideally be the last resort. And this was actually our second case of IVL that we performed at our center a few months ago, as soon as we got it. And it seemed really like a magic wand, because seeing that grumpy dog boning, when we proceeded to IVL, it was a really rewarding experience, to say the very least. So in that case, which diameter? So we know that 1:1 or luminal diameter of whether we should take it as 1:1 or luminal diameter of the disease segment. The recommendation is to take a 1:1 inflation, but given that this was an early experience and the crossing profiles of the devices were also a little bulkier than regular devices, we decided therefore to take a 2.5 by 12 shock wave balloon, especially also bearing in mind that there's a stented segment there. So following 30 pulses, you could see that the first 10 pulses, there's still some dog boning available, visualized there, but it gradually gets better. This is the first 30 pulses. We then finished it with another 10 by 20 pulses each. And you can see that there's maximal expansion at that point, just distal to the segment with the significant calcification. So these are the pictures after, the intravascular imaging pictures after, and you can see that there are some very nice cracks visualized of the calcified segment there, which is post-IVL and which did not yield with an NC balloon. So after further dilatation by stent, after further dilatation, we by NC, which we followed it by, we proceeded to stent with a 3x31 millimeter easily deliverable drug-eluting stent, which overlapped, of course, the previous stent and covered the proximal in-stent restenosis, proximal lesion, as well as the distal calcified lesion. And this is the final angiographic result. And we followed it with IVUS also. So in terms of calcium management, we know that previously, at least in our region, these all had to be tackled by rota, and these are lesions that are not easily yieldable by NC or scoring balloons. So the only other option we previously had left was rota, but now we have intravascular lithotripsy with evidence from the DISRUPT-CAD study series as well. So it seems really like, as I said, it was a very rewarding experience because unlike atherectomy, IVL requires no specific training. It just requires the ability to inflate a balloon, and therefore the learning curve is very minimal. The risk of atheromatous embolization may be lower than the free bulking devices like rotational atherectomy. Plaque modification is not subject to guide wire bias, which is significant, and an effective circumferential modification of calcific atheroma is possible. And also it's performed at a low atmosphere. Its IVL is inflated at 4 atmospheres, minimizing mechanical vascular trauma as well. And side branch protection using a guide wire may be easily performed in the event that you need a side branch overall, without the risk of wire entrapment or severing, which is a problem with rotablation. So with that, I am happy to share our first IVL experience at least, and I'm happy to have the floor open to discussions. Thank you for the opportunity to speak.
Thank you, Aisha. Over to Dr. Agarwal for his first comments, and then we will discuss.
I think what she did was good, that she did IVL, and that the lesion was much more better on doing an IVL, and then the things have improved quite a bit, and that was the right way to do it, and what she did was right.
Dr. Amit Kumar, any comments from you?
Yes, sir.
Any comments?
What are the contact indication of IVL? Any contact indication of IVL?
Aisha?
So I guess in this case, not really. The only problem is that it has to be balloon crossable. So it's not a contraindication. It's like it's more like a challenge or a non-use of it, because even in a very calcified lesion, unless it is a balloon crossable lesion, you're unable to use an intravascular lithotripsy balloon. So since luckily, and that is why I think in our experience, we've seen that maybe even if we do a bit of granuloplasty and cross the balloon, once you're able to cross it, you're able to use IVL. But if not, we would have had to use rotational atherectomy in this case.
Okay, thank you.
Dr. Uday Shankar, any comments? Uday Shankar? Okay, Aisha, a couple of points. One is that for calcium, I think the OCT is definitely a better modality for imaging, for the simple reason that, the 3 criteria we know about: the depth of the calcium, thickness of the calcium, and the arc of the calcium is better delineated in the OCT. And secondary, I think if Amit Kumar was asking about contraindications for IVL, I think if you have calcific nodule, that is something which will not be tackled by an IVL balloon. So that is one thing which is very, very important. So I think the case was done very, very nicely. But I think, Aisha, do you have OCT in your lab right now?
No, actually, as I mentioned, I think OCT would be the far superior modality for exactly the reasons you
Yes.
mentioned. But unfortunately, we don't have it in our lab. And I agree, calcific nodules, they are the bane of our existence, right? So I think even with rotational atherectomy, and there's still lots of schools of thought about how to deal with it. So some people have actually recommended that you can try IVL for a nodule, but of course, rotational atherectomy is probably the better option there. But yeah, we
I
hope
think
to
the
get
idea,
OCT.
the calcific
Yeah.
nodule can be dealt with if you have a wire bias during the rotational atherectomy. That is the way ablation. That is
Yeah.
one of the ways they mentioned, but it's not a full technique yet. But I think
Exactly.
we should get a volume center like yours. Definitely OCT for calcium treatment is the way forward. But do you have high definition ultrasounds?
No.
IVUS?
So we haven't upgraded IVUS because we're waiting for OCT. Actually,
All right.
it should be getting to us soon. So hopefully, once that's the case,
The best
we have
is the
OCT
OCT,
in
but I
2
think the second
centers.
best
Yeah.
is they say that it is the HD IVUS. But I think if you have both the imaging modality, I think it's very easy. Particularly in cases where we have calcium and patients with renal failure, then you do a pre-OCT and post
IVUS,
kind of a
right?
IVUS. So that is the best way to do it. And I think that is a very, very important modality. But it's a beautiful case. The left side, what do you think? I thought there was, if you go back to the left coronary angiogram, I thought LAD had some kind of a lesion which is maybe developing over the last 2 years.
Correct.
So, and that was very calcific as well.
LAD was very calcific, and you're absolutely right. It was moderate. We are hoping to do an FFR of that and bring him back for it, because I think that would require further, because we don't want to touch it because of the calcium without absolutely having to physiologically assess it for physiological significance.
There's something brewing there, I think. The left
Definitely,
artery. Yeah. So, so what do you think is the pathology in these 2 years? That the stent was intact, but you had 2 stenosis before and after the stent.
So technically, it would fall under the definition of an in-stent restenosis, but I think his calcium is also a recalcitrant sort of calcification, and perhaps it could have been there was also an underexpanded segment of the stent there that could have been a harbinger for the ISR later, just proximal and distal to it. But I'm beyond that, I'm not particularly sure. Maybe I'd invite thoughts from you about what the pathology of it might have been.
You see, when you did the first, the 2 years back when the angiogram was first done, it definitely looked like a CTO and not a acute thrombotic occlusion. But the wire, I think, crossed relatively easily also in that CTO segment. Because I thought there was definitely bridging collaterals in that segment. But yeah, I mean, the stented segment probably was exactly on the site of the lesion. So pre and post at that point of time was not interrogated with any kind of imaging. So I think if you had the imaging at that point of time, you would have had better results at that point of time. So thank you very much, Aisha, for your excellent presentation as usual. And if you could stay on, if your cases are not been taken, you can stay on for a while I invite Dr. Amit Kumar to present his case. Thank you again, Aisha.
Thank you very much for the thoughtful comments and the discussion. Thank you.
I invite Dr. Amit Kumar to present.
I'm sharing my screen. Yeah.
Young male with right-sided hemiplegia and dyspnea.
So young male with right-sided. My case is young male with dyspnea and right-sided hemiplegia. So history. 24-year male came in ER with acute onset right-sided hemiplegia, and he had history.
Sir, make the slide full screen.
24-year male came in ER with acute onset right-sided hemiplegia. He had history of dyspnea and chest pain on and off from last 3 months. Risk factor: he's being chronic smoker with more than 20 packs per day. ECG showed QS wave in chest lead V1 to V6. On echocardiography, anterior was kinetic, and there was LV apical clot of 32 into 22 mm and EF was 30%. Basically, the LV clot was embolized and it caused the right-sided hemiplasia. So angiography was done and we found that single vessel disease involving LAD with 100% occlusion. JCTO score was 1, and we can see the angiography for the further. So we can see the LADs. We can see the LED CTO with taper end, and we can also see the.
The slides are not visible, Amit. The angio is not visible.
Hello.
Hello.
The video is not visible or what? And just wait. The video is. So
Find the next slide.
Can you see the video?
No, not able.
Sir, fast. Click on share screen.
Actually, I have. Can you see the video, sir? Hello, can you see the video now?
No, not yet.
Not yet. Okay. I'm saying in slide. I have video.
Sir, when you try to share the screen, just click on share sound and share optimized video option.
Pardon? New share. Share.
First click on share screen, then you can see the share sound, share and optimized video clip option.
Yeah, share sound and optimize video clip.
Yes, just click on those buttons.
Now I say my video. Now you can see the video. Hello. Can you see?
No, not yet.
Not yet. Okay. Can share my slide then. I am slide. I have the video. Sorry.
Sir,
When
you try to share the screen, select the screen option. Screen, not any PPT. Select the screen. Then you can click on share.
Okay. Share screen.
Yes, just share sound and optimize video clip option, and then select the screen.
Yeah, I shared. Now,
Yes,
now we can see it. Yeah,
Yes.
we can see it.
Yes, sir. So now we can see the LED is 100% occluded, and we can see a long stump of CTO, and we can see the next video. Different view. We can see the in the LA portal. We can see also see the video of we can see the proximal LED is CTO. And the next. Then in the LA canal, we can see the picture of LED CTO. After that, we tried with the whisper wire, but it was not crossing. After that, we sculpted the wire with extra wire. The extra wire was also not crossing, and it was the wire was just buckling in the proximal stump of the CTO. After that, we escalated to Gaia 2, and somehow it crossed the lesion and it reached the distal stump. After that, we crossed the wire and reached the distal end of the vessel, and after that we did epidilation with 1 mm balloon, and followed by that we did epidilation with a 2 mm balloon. So now we are getting a good flow in the AD vessel, but the wire is in a different branch. So after that we replace the wire in the LED branch, and now we can see that we are dilating with the 2 mm balloon, and after that with good pre-dilation, now we're getting good flow in the LED vessel, and after that we now we're getting good flow, and after that we put a stent of 3 into 28 mm in the proximal to mid LED, and we inflated at 14 ATM, and after inflation, and we had a good flow in the LED. I just lost the screen. So after that, after we had a good flow in the LED with the stent, so we just did our first CTO in this. We did our first CTO in the center, and patient was fine after this procedure. It's very. So with this, I end my slide. Thank you.
Thank you, Dr. Amit. Dr. Agarwal, your comments, please.
Yeah, I think the artery looks like, the LED looks like almost 100% obstructed at the time when the patient was being investigated for. But he did various manipulations, and in that ultimately he became successful. But I still don't know if it's a good intervention done or not, though the artery looks okay. So I think something more can be done to the patient. He is so young and has developed a stroke and all those things. So maybe, I don't know. I think if you had the evidence, doing some investigation, which would have said for definite that would be okay and that is enough.
He was chronic smoker, sir. This was the main risk factor. He was very chronic smoker, so this led to anterior MI, and it was an old MI because he had a history of 3 year. He had a history of pain.
Yeah.
He had a history of pain 3 months ago, and after that when he had hemiplegia, then he presented to the ER. He was not presenting before, so it was an old case of old anterior MI.
I don't know. I'm still not sure if the artery is good or whether he will be able to sustain this artery on long-term basis.
Okay, Dr. Kader, if you're around, could you make some comments? Okay, so Dr. Amit, this is a good case. The only thing, as Dr. Agarwal had pointed out, is that this young man had a EF of what, about 36%. That's what I saw. So
Yes.
what I would do is
30%.
in this particular case is to do a viability study to make sure that, the effort we are putting in to open up the LAB, is it worth it or not? Number one. Number two is that when you are crossing with a hardware like the Gaia wire, and you crossed and you saw it was in a diagonal, it will always better to put a microcatheter and exchange the wire to a softer wire. That will make life much easier. Particularly, you wouldn't want a CTO wire to be hanging around in the distal coronary artery while you are manipulating your balloons and stents. So technically, I think that is one thing to use the microcatheter in this particular case. That would be better. And what did you do about that LV clot which he had? I mean, what happened to the patient?
So he was on oral anticoagulant, and now his clot has disappeared. He has came in the follow-up, and he was on oral anticoagulant along with clopidogrel for 6 months. So he's doing good.
Okay. The other thing which Dr. Agarwal was also mentioning, I didn't think that you had a TB3 flow at the end of the procedure, because the distal flow was not very good.
His TB2 flow was there.
Yeah. Dr. Agarwal, would you agree with that? That the flow was not TB3?
TB2 flow, so it was an old case.
Yeah. So I think these are the couple of points is that when you have anybody, with the ejection fraction 30%, the kinetic ventricle, to do a viability study before we proceed for a intervention, that would justify the amount of efforts which you are putting in to intervene. So I think what you need to do is probably to follow up on this case and to see whether the ejection fraction is improving or not, and to also check his cholesterols and other areas, because why should somebody have MI and a stroke at 24 years old? So did you check carotids and all? I mean, whether they are okay or not?
Well, fine. Homocysteine was also fine. So homocysteine was done. He was fine.
All right.
Also fine. So I did all the investigation, and the only thing which I found was he was chronic smoker. So I think that led to the.
That has to stop. Yeah. And I think the oral anticoagulation has to continue for a while, particularly in this patient.
Apixaban primary BD along with clopidogrel primary just so.
And he was in sinus rhythm. He didn't have any.
Yes, he was sinus rhythm. Yes.
Yeah. Okay. So thank you, Dr. Amit, for your excellent case. Unfortunately, we do not have Dr. Dhananjay Kumar and Uday Shankar present his cases. So I think we'll have to end our session here. So the concluding remarks, I asked Dr. Agarwal to make the concluding remarks, and then we can end our session. Agarwal.
Yeah, I think both the cases have been good. Dr. Ayesha spoke very well, and she showed the IVL treatment and the success of it. So that was good. And in your case, I think you could have treated it as a CTO of LAD. Then that could have done things better.
It was CTO only, sir. It was CTO only, 3 months.
But CTO only, but it was not the way it was to be. Like CTO, basically, you try to do a CTO, basically.
So anticoagulant approach was done because I was seeing the stump was good. Both proximal and distal cap was good, so I did anticoagulant approach.
But ultimately, it ended well. But I think you have to follow up the patient.
Yes, he is doing good on follow-up also.
Okay, thank you so much, Dr. Amit Kumar and Dr. Aisha Kadir, for presenting your cases. And I also thank our chairman, Dr. R.K. Agarwal, for his excellent comments on both the cases. So I think we will finish our session here, and looking forward to seeing you again sometime, maybe offline this time, in one of the meetings. Thank you again, and have a good evening. Thank you.
Thank you.
Thank you, Dr. Dev,
Bye-bye.
for a very nice presentation and very nice